need is dramatic, and the stigma is incredible, and women and their children suffer needlessly. So I think we've got a lot of work to do. One of the problems with doing a talk is doing the research and trying to come up with facts. And you look at a book, and then you look at a paper, and then you look at another paper, and you go 4 to 20%. And you go, well, is it 4%? Is it 6%? Is it 20%? I mean, it's 4 to 20% is a five-fold difference. This is not, these are all, good papers. They're all good textbooks, but it's just some of our limitations in terms of our science right now. Some of it is due to stigma because it's psychiatry, and some of it is just due to a lack of funding, and some of it is just due to, I don't know. So in general, depression actually affects 1 in 5 people in their lifetime, okay? Men and women. It's 20% lifetime prevalence, okay? So it's a huge, huge issue. So I don't know how many people we got here, but at least 2 of us will have it. Statistically, at least 2 of us will be affected, okay? So now, one of the things that happens, and we'll talk more about it, is that hormones really fluctuate during pregnancy, especially at delivery, and we talk about postpartum depression occurring in 10 to 20% of people. So now, depression during the pregnancy, has its own set of complications. So, the main thing, that I do whenever I'm looking at, a situation, whenever I'm looking at prescribing medications or not prescribing medications or prescribing psychotherapy or whatever, it always comes down to the risks, the possible risks, and the expected benefits. Okay, it's always a balance because you're always weighing it. It's not, you're faced with a problem, and there is no magic solution. Okay, we would like to have some magic solutions, but there aren't any. And so unfortunately, in our country, partly because of the legal system, we're very risk averse, especially physicians. We don't want to get sued. So a lot of times, it's easier not to do something than to do something and have a problem. So if you ignore the depression and there's a problem, you can't really get sued. Okay? Because you didn't do anything. You didn't notice the depression, you're not going to get sued. If you do notice the depression and you prescribe a medication and something bad happens, whether it's because of the medication, whether it's because of the underlying depression, or whether because bad things happen, as a physician, you've done something, so now you can get sued. So it's not the best way to go about life, but it's the way it is. Okay. So what happens to the fetus? Moms don't get the health care. They don't eat well. They abuse substances. They smoke cigarettes. You've got diabetes. You've got all sorts of problems. You also have increased inflammation in the child's brain because of the mother's depression. Okay. So we're learning more and more about the link between depression and other mental illnesses and inflammation. It's fascinating, and we're learning more about it, but we still don't have quite the information. So if you don't treat the depression in the mom, and she's depressed at about 25 or 26 weeks, okay, of her pregnancy, so the brain has cortical thinning. Okay, so what does that mean? That means the cortex of the brain, okay, which is the outer layer of the brain, is not as thick as it should be. So, okay, so the kid is not as smart. Okay, that's a translation. All right, and there's other physical anomalies that we can find in the kid's brain. Okay? This is in addition to some of the other stuff we talked about earlier with the undernutrition. Well, what about newborns and moms with depression? Bonding, breastfeeding, care for the child, cognitive, emotional development. So, okay, now, Marjana is from Poland, and she actually has been coming to Alachua for the last 8 years, 9 years, to train in bioenergetics therapy. Okay, bioenergetics therapy looks at the body and looks at what happens. Sort of looks at the body in the sense that we're looking at what happens in the first 3 years of life, and basically looking at pre-verbal memories that are in the body. Okay, so it's an outgrowth, directly outgrowth from Freud's psychoanalytic theories, and it's looking at it. And so I've also undergone the training, and it's to me it's absolutely fascinating, and really it all goes to that maternal-infant bonding, how well it's done, what happens, and the consequences that at least a lot of analysts see and when it's not well done. Now, the reality is it's never perfect. Okay, you can't, I mean, part of life is frustration and gratification that doesn't happen when you expect it to. Okay, so that is part of it. Okay, but there are ways to sort of decrease the risk, and there are ways to make things a lot worse. Okay, when moms are depressed and they're unable to, react to a child's need, or they're overwhelmed by the child's needs, it's going to be a lot worse. Okay, and the consequences are really lifelong. Okay, so we're going to talk about treatment options, and we're going to start off with the most interesting one, at least at this point, which is repetitive transcranial magnetic stimulation. So why is TMS interesting? First of all, it's interesting because it's newer. It was approved in 2008, but of course, people still think it's experimental. And of course, there have been very, very few studies done in pregnancy. There are some centers, there are 2 centers in Los Angeles in particular that have a fairly high volume, but they haven't published that much. So what is TMS? It's a localized magnetic stimulation, okay, and usually it's to the left side of the cortex, and it stimulates that area, that circuit. There's a whole circuit that it stimulates, which alleviates depression. It is time intensive. Generally, it's 5 days a week for 6 weeks. It's an hour-long sessions, but in younger people, it's usually shorter duration. Risks, there are some in. There is a potential risk of seizures because we are stimulating the brain. It's very, very rare. And it's a localized treatment. So we actually had our technician was pregnant for 9 months during and had her twins, and knock on wood, things, so she really had a fairly extensive exposure to that, to the TMS. But the effect of the magnet decreases exponentially with distance. So, at least in theory, the fact that you have a magnet on top of your head, the effect on the fetus is very minimal. Okay. So this is what our TMS machine looks like. Okay, and this is what the circuit looks like. And so it really affects, so you put the magnet right on top of the prefrontal cortex, and the magnet affects an electrical stimulation of the neurons, which then sort of goes around, right? And decreases the amygdala's response, increases the others, and decreases the amygdala's. And so the amygdala is sort of your stress and fear response. So that is decreased. The other ones are increased. Your depression is alleviated. To me, it really should be first-line treatment in pregnancy, because it's the only non-systemic. It's the only thing that is localized. Okay? It doesn't go anywhere. As far as we know, it doesn't go anywhere. Okay? So the SAGE is starting a clinical trial, a very interesting clinical trial, and it's based on the fact that allopregnanolone, which I will call allo from now on because I'm lazy, there's a very severe drop in around the delivery in allo, and so the theory is that severe drop causes the depression. Okay, you with me? So the research study is a 3-day infusion of allo. One of the issues is that, well, it's 3 days, so people, the women are going to be in our offices for 3 days. The babies can be with them, but they're technically not allowed to breastfeed during that time. They can pump and save, pump and not save it. And eventually they can resume breastfeeding at some point later. Because, again, we've got a lot of attorneys that if we had fewer attorneys, we wouldn't be nearly as worried, because this is a physiological hormone that the fetus has been exposed to, for 9 months, and it really increases right before delivery. So, okay. The good news is that the FDA was very impressed with this. So this was a study, 10 people on the SAGE on allo, and 11 women on placebo. And you can see, and this is pretty dramatic drop. All right, so they all start off at 29 up there, which the Hamilton depression score. And you can see that in the first 6 hours, but definitely in the first 12 hours, there's a huge difference already in the depression scores. Okay, and by hour 24, it's really, you don't see this in any other depression study. Okay, when you have 10 people in each arm in a depression study, to get a significant difference from placebo, it's just insane. This is like incredible. And so this is 60 hours. You're still seeing that difference. And on day 7, day 30, you're still seeing a very huge difference. So really a very dramatic enough to so that the FDA really wants this study done, and they're pushing it.
What do we think that some of the significant effect of the placebo is? Because this is taking place in locations like yours. Is it that?
Well, honestly, that is really pretty good. In terms of placebo response, it's not huge. We have the placebo response rate has dramatically increased in every single trial. So we've 6 years ago I would have told you that there would be no placebo response in an autism trial. And we've had an autism trial, we've had a huge placebo response.
When they were receiving the SAGE, were they continuing to receive it after they left?
No, that's it.
Hours? That's it, okay.
It's the end of the infusion at 60 hours.
Okay.
And then it's just follow-up. I follow up until day 30. Okay, ECT. ECT has gotten a bad rep, very bad rep. Ever since one flew with Cuckoo's Nest, where they confused ECT with brain surgery. It's like, it boggles my mind that, they would do such a thing, but they did. Movies don't have to, they can do whatever they want, I suppose, but they actually, ECT does not have the kind of effects that it had in One Flew Over the Cuckoo's Nest, but, it is not indicated for mild cases for sure. It does have some significant memory effects, okay? In some people, much stronger than in others. And but really, it's a very rapid response, and it is with the improvement in anesthesia, it's really very, very well tolerated. So again, we used thalidomide for a long time, and we got a lot of birth defects later on, and it really kind of scared people. So the good thing is that we don't prescribe medications to pregnant women, and the bad thing is that we don't do research on prescribing medications to pregnant women. We just okay, close your eyes and nothing bad will happen. Well, bad things do happen, but anyway. So pregnant women are considered very vulnerable, and we really are very limited in terms of doing research. The benefit is to the mom, the risk is to the fetus, and it's just difficult to follow up, to see what a 5-year-old looks like. If the mom was treated or not treated, what does it look like at the age of 5 or 10? So it's a bit difficult. Antidepressants are used. The nice thing about the first two, Prozac and Wellbutrin, is they have databases that they've strongly encouraged psychiatrists to use. So I think other companies have databases, but I certainly haven't been contacted by them and actively sought input. So the database is good because let's just say you have a woman in the 3rd or 4th month, and you put her on a medication, and then you get, you follow her up and you see if the child has any problems or not. The problem with sort of not doing that, not having, is that when there is a problem, it gets reported, and when everything is normal, it does not get reported. So when you have a database, you're actually looking prospectively. So anytime you see a patient and you're going to put that pregnant patient on Prozac, you call up Eli Lilly and you tell them you're putting that patient on Prozac. And then you follow the patient out and you go, okay, the baby was born, had this problem, baby was born, didn't have any problem. Okay? Because otherwise what happens is that babies with problems get reported. And so that's what happened with lithium, for example. Okay, so lithium was blamed for many years, and it's still in the literature blamed for cardiac malformation called an Epstein malformation. And other researchers have studied this, and they find that it doesn't happen any more than your baseline malformation. So, because it wasn't well controlled. So then you've got these long lists of, things that, may cause harm. You've got, Buspar is the only one there's no evidence of risk in human pregnancy. So these are all the old antidepressants like Elovil and Lexapro, and Lexapro and Celexa, a recent study have done relatively well versus the other SSRIs. Paxil has done really poorly, actually. So they've discovered that there is a small, statistically significant link between paroxetine, Paxil, and microcephaly. Okay, and then you've got minor physical anomalies with the other SSRIs. So what's a minor physical anomaly? It's like maybe missing a digit or having some sort of small malformation. Nothing too dramatic, but obviously nothing that you want. So, but again, very rare. So what do I do when a woman is breastfeeding? And I want to reassure me and reassure the woman. I try to get a blood draw on the kid, on the fetus, of the antidepressant. Okay, and hopefully, in most cases, it's been below the detectable level of the labs. Now, if you get a scientific lab, a research lab, can probably determine, what the level is. But as long as it's below the technical level, I figure we're relatively safe. Okay. Wellbutrin is my go-to antidepressant, unless there's a lot of anxiety. And it's been, there's no evidence of risk. So the problem comes with mood stabilizers, where lithium, again, it's been given a really bad name. It doesn't deserve it. On the other hand, both Tegretol and Depakote do have some positive evidence of risks. And Depakote has, we'll see on the next slide, lamictal lamotrigine seems, as of now, this could be different tomorrow, but as of now, it looks pretty safe during pregnancy. Okay, so Depakote can cause neural tube defects, it can cause some facial anomalies, it can have some cardiac effects. It's really not. Tegretol also can cause these problems. It's not. These are not good medications. Unfortunately, a lot of times, women having their first psychotic break or their first, this is for people that have bipolar disorder. They're put on these medications, at the beginning, and they may become pregnant. So no evidence for psychotherapy, but it works. Acupuncture may help some people. Light therapy is definitely works very well for seasonal affective disorder. So for some women, some pregnant women, it may be helpful. Exercise is amazingly underutilized, and then we've got supplements. Okay, some risks of pregnancy, cigarette smoking. Again, IL-8 is an inflammatory marker. And if a woman is smoking cigarettes, you've got an increased inflammation in the child, which then causes all sorts of problems, most notably cardiac and brain-wise. We all know about fetal alcohol syndrome. We don't really know much about marijuana because you really have to be like Johns Hopkins or Harvard, top psychiatrist to get a dispensation from the Pope to be able to do research on it. So this is new, it's interesting, and omega-3 fatty acids, and they gave healthy pregnant women, lots of omega-3s. So, and what they found is, a very significant difference in P50 inhibition. So, what's a P50 inhibition? It's measured at 5 weeks. It's a biomarker, and it measures cerebral development. Which corresponds so the 5-week biomarker corresponds to inattention at the age of 4 years. So it's a really pretty powerful biomarker for a 5-week biomarker. And it's also a risk factor for schizophrenia and genetically. In that population, it's obviously not the only problem. And this is what it looks like. So basically, you've got a paired stimuli. You've got your first response, and then you've got your second response. All right. So the normal. So this is these are the ones that have received the omega-3s. So your first response. So when you first get an auditory stimulus, you have a fairly intense response. When you get a second one, you've heard it already. Your response is much lower. Here, these are the placebo. So the first response looks the same. The second response looks more like the first response and not like the normal second response. So it's an evoked potential that is measured. So you make the noise and you measure the electrical activity in the brain. The electrical activity in the brain on the first time at 50 milliseconds is measured this way. With the second sound, The normals, they hear it, okay, but they don't. Their reaction is much more muted the second time. Whereas the fetuses that were on placebo, where moms were taking the placebo, their reaction is a lot closer. It's like they hear it different. They don't mute it. Okay. Does that make sense?
So are you saying that the omega-3s can protect the fetus's brain from
Right.
the effects of the medication the mom's taking, or the omegas-3?
No, this is healthy pregnant women that don't have depression, that don't have
Okay.
anything.
Okay.
Right. So it helps. It really helps brain development, and it's something that is, again, one of these things. There's no drug company pushing it because it's not. It's not under patent. So most doctors don't know about this, really.
So this is just more
Clearly.
in regards to the infant's brain development over time, rather than
At 5 weeks.
to like a woman's.
So this is the brain, the infant's brain at 5 weeks,
Right, but it's,
which correlates with their attention level at 4 years old.
so it's more about their brain development than about the woman's
Right.
depression. or
Right.
anything like that.
Right. Yeah, this is just healthy women.
This is just healthy babies, to make babies healthier.
Okay.
I understand.
And so postpartum depression apparently in Singapore does not exist. Yeah, this is we're advertising for Northwest Seafood. They don't know about it, but we are. In South Africa, it's 25%, and then just unfortunately the numbers that I have that I was able to get don't correspond. So they're really there's not enough omega-3 in intake in South Africa relatively to Singapore. So in Japan and Norway, you've got a median intake of 1,000 milligrams a day, and Australia is 15 milligrams a day. So there's visual and cognitive benefits, and it reduces the risk of allergies and asthma, which came out in the journal yesterday. Okay, so this is hot off the press. Actually, I didn't even receive the journal yet. It's on my email notification. So go to Northwest Seafood, go to Dragonfly, or take 2,700 milligrams in the morning and 1,600 at night. All right, so increase seafood consumption, increase DHA levels in breast milk, and decrease depression in moms. So, what am I saying? And I've said a lot of different things. What am I saying? If you don't treat the mom, okay, it's a risk to the mother, but it's also a risk to the fetus and the newborn. Nutrition, bonding, psychoanalytic, etc. If you treat the mother, there is a benefit to the mother, but there's a risk to the fetus and the newborn that really they're not well quantified. Okay, now, so the most difficult part actually is that the risks of the medications are greatest in the first trimester, when most women don't know they're pregnant yet. So by the time they come in and tell you they're pregnant, the risks are really over. So it's really kind of a complicated scenario. So the last thing you want them to do is have had the risk and then take them off their meds, because it's a lose-lose situation. They've already been exposed to the risk, and now you're taking the benefit of the medication away. Okay, so the treatment options, we've talked about TMS, which is localized. Really, the harm to the fetus is theoretically nil. It is time intensive. We need more research. Aloe looks really good for postpartum depression, and it has really immediate benefits. Basically, the breastfeeding hold seems to be the biggest problem at this point. SSRIs and other medications are systemic. They will have an impact on the fetus. Paroxetine is the worst. Prozac is the best studied. Wellbutrin and Lexapro are probably the two that we think right now are the least problematic. And omega-3 supplements should be given to all women who may possibly become pregnant at any point. And when they do become pregnant, we should increase the dose significantly, unless they're dragonfly addicts.